Okay. Okay, so good evening, everyone. So like I said, like what I was talking about, I was reading everybody's post, and I really enjoyed reading the concerns and the ethics questions that were posed, especially the ones from you, Nina. The uh, the the research patient
Pharmaceutical
research.
research, yeah, it's an
Yes,
ethical mess.
yeah, and the reason why I resonate to it the most is because I work in when I work in surgery, and consent is part of one of the bigger roles in my field, and that's what my reflection is also all about. But with that, I will segue to you and let you start your discussion.
All right, let me see if I can get the let me time. The app's not working. 1 second. Okay, can you guys see the timer app?
Yes.
Okay, cool. Yeah, so just a quick summary of mine. I was really interested in the optional reading. There was like a little article about 6 Swedish research nurses who worked in a hospital, feeling a little conflicted about their job. And, as nurses, we're here for our patients, but research, those priorities kind of get a little bit murky. And I was like, oh, that's my job. Um, that's what I am trying to figure out. So I'm just pulling up. I printed out like all of your posts and I forgot to print out mine. So I'm just pulling mine up super fast. But I was really interested in that article, like I said, because I work in research. I've been there for 2 years. It's outpatient pharmaceutical research for some context. Um, but the article talked about how these nurses felt like they were getting steamrollered by doctors. They didn't feel comfortable following the orders, especially because they were prioritizing data over patients. And I was like, yep, I feel that. So I referenced the second provision for the ANA Code of Ethics about your primary commitment being to the patient. And I have lots of examples, but I just kept it to one. So we had this polycystic kidney disease medication, which actually does some really cool stuff. For the patients it works for, it actually bumps up their GFR and then maintains it, which is very uncommon for kidney disease treatment. Everything else is basically just trying to slow down the kidney disease progression. So what it did to the kidneys was really cool, but it had a lot of nasty side effects. Like it could give you heart failure. It could worsen existing heart failure. We had some patients who did the study who got like funky rashes that had to be biopsied and they had their liver enzymes jump up. So I was like, oh, I don't know that I want to enroll patients in this study, but that's part of my job to enroll patients and to find them, recruit them, help out with the ads, call patients inside our own database, those kinds of things. And the pharmaceutical study, the company, they'd been running studies on this drug for like 10 years and things were kind of slowing down and the FDA wasn't really sure about it because they'd run it by the FDA a couple times. And so they were really putting the pressure on us to find more patients. And I just didn't feel super good about that. And then my study doctor was just totally checked out. I actually haven't seen him in like 4 months, which if the FDA finds out, he could get kicked from research. So I've got my own feelings on that. So total disaster where I just don't feel comfortable enrolling patients. Complicated by the fact that they're essentially my paycheck. Of course, the pharmaceutical company doesn't directly pay me, but they pay my company and then the company pays me. And they also fly us out on these really flashy training trips. So this specific protocol flew me out to Vegas earlier this year to like hype us up about the study and encourage us to enroll more patients. So just reading this article and feeling like that struggle between, as a nurse, my commitment is to the patient, but as a research nurse, I've got all these people piling on me about data and enrolling and recruitment, and that's not really what I'm here for. I'm here to provide good treatments to patients, and I was not sure that this was a good treatment. So I absolutely resonated with that. And then my suggestions were, I agreed with the article suggestion of having ethics rounds. So like interdisciplinary teams could meet maybe like once a month and you can talk about ethical dilemmas you're facing, or if no one's got anything to come ready with, you can have like an ethical principle to talk about, something to do more trainings. And then my second suggestion was to work in research, you need to have something called your good clinical practice certification. Which is something that all research staff have to do before they let you anywhere near studies. It's an international certification. And you only have to renew it 2 to 3 times a year. So it can get kind of fuzzy. There are ethical trainings, of course, as part of that, and they're great ethical trainings. But when you're only doing it every 3 years, you kind of tend to forget how things are. And in the meantime, all training you're getting on research is coming from pharmaceutical companies whose priority, of course, is not the patient. So those were my two suggestions to kind of address that. point of tension. Yeah, any questions, thoughts? That's my quick summary of what I wrote.
Okay. So from my perspective, how do you consent your patients? How do you can you tell me more about how you enroll them, and how does it play a role with their understanding of what they're getting and what they're undergoing?
Oh, sure. So for each study, we have what's usually like a 20-page PDF. It's approved by the IRB, which is the Human Rights Committee that oversees research and other things as well. So we have like this 20-page PDF. It tells you what the visit schedule is like what activities will be done at each visit, how long is the study going to run for, what are side effects, what are risks, how much will you be paid, basically everything a patient might want to know. And that's the other tricky thing too. That's another ethical dilemma. I feel like consent forms are not written at a low grade enough level for patients to understand, because it's supposed to be a 5th grade level, but we also have some pediatric studies. So I look at the pediatric forms and I'm like, this is what the adults should be given. Like that's the level they need to really understand, because they don't know what they're getting into. Like I'll go back in the room after they've had time to read it and I'll say, what questions do you have? They say, oh, no questions. And I say, okay, well, we're still going to go over the main points. And then I'll go over the main points and they'll go, oh, actually, I didn't understand this, or, oh, okay, that's what that meant. I'm like, oh my gosh, like you're just willing to sign up to be a guinea pig and you don't even like know what you're signing up for. Like you could be signing up for 5 years of experimental infusions, so that's what our consenting process is like. And then of course the study doctor is supposed to be generally around, so if the patient's got medical questions that are outside of my scope, then I'll go bring the doctor in and then the doctor will talk to him. So I'm sure for surgery it looks different. I haven't had much to do with surgery, so.
Okay, and the reason why I had to ask that question is because even on surgical forms, even on surgical consent forms, the wording for the procedure is it's almost as if it's like if it's a 5th grader that's coming into surgery, they wouldn't understand what's going on.
No.
They will just go for what the surgeon or the surgical team just tells them that they're gonna go under, and they're just going off of the explanation of the nurse, of the resident, of the doctor, and all those things. And I think one of the and that's one of the things that I am very adamant on, is like understanding what you really are going into and not just jumping on it. So yeah.
Yeah, we always hit the side
for
effects sections, and I'm like, I'm not going to sugarcoat it. Like, we're going to talk about the side effects. If there's any you have questions about, like, how common is this, or we're going to talk about it. Like, and it's kind of tricky too. While I'm talking about consents, research for pharmaceutical research, consents will have some section that says something to the effect of, if you are harmed as a result of this study, the pharmaceutical company will pay for whatever your insurance doesn't pay. Like, you have a freak allergic reaction, like whatever your insurance doesn't cover, the pharmaceutical company will. But only if they decide it's related to the drug. So they'll like try to weasel their way out if something happens and they're like, oh, I don't know if that's exactly it. Like the empagliflozin, I don't know if you guys are familiar with, it's a diabetic medication that makes you pee out the glucose. So your pee is full of sugar. And so we had a patient get a really nasty UTI, and the pharmaceutical company was like, well, that's like not like actually a side effect. And we're like, her pee is full of sugar. So like it logically follows that we probably put her in the hospital with the UTI. So like, anyways,
so I think that brings like kind of just my question. We were talking about the comment that you had made, the pharmaceutical industry is not for the patient, of course. And then us being like that middle person, and you kind of hear about that, like, oh my gosh, this could have, you just brought up the high urine, the, glucose, the sugars in the urine and stuff like that. And then how they just try to back out of, well, this isn't ours, because of course it's financially driven. There's a bottom line, and they don't want to have to pay the money to fix maybe something that their, drug did. So just from like a standpoint, from like a heart space, and knowing that these things can happen. I mean, it's nice to hear that you really go over these points, because the consents, and honestly, when I read some of these things, I'm like, I don't even know what the heck that means, or I don't even know. I have to look up, like college words sometimes. When we were reading some of these papers, I'm like, some of the in one other class, I'm reading some of these like papers, I'm like, I don't even know what that word means, and I have to like look it up. So I think that's awesome when you're talking about just the whole ethical principles, like do no harm to patients, and make sure that kind of like the duty to warn, if you will. Well, you are saying you want to, enter into this study, and here's what I need to tell you. And then it always does. It sparks them. Oh, I didn't realize that, or oh, I didn't know what that meant, or oh, I actually do have a question. And so just making sure that they are 100% informed, I think, is awesome, because I do think, yeah, a pharmaceuticals definitely does not have the human, the patient in the forefront of any of that research. So it's nice that you recognize that, and it just kind of, it hits a chord with you.
Oh
I
yeah.
like
Well, I
that.
think
Mhm.
working as a research nurse, the way it works for every study is your company tells the pharmaceutical company what your enrollment goal is. I don't remember what it was for the polycystic kidney study, but they hold you to it, and they were like on my
Mhm.
case about it. Like, you promised us this many patients, and I had to be like, I didn't promise you those patients. My company promised you those patients, and I'm concerned about the side effects. Like,
Yeah.
it's hard to push back
So do
against big
you,
pharma.
so in the, but do you find there's a, because you're like, okay, yes, we have, my company promised this many patients, but yet the side effects. And as nurses, our job is, or our main concern is typically the patients. And so do you find that you're like in this, like, I have to do what my company said, and this is what I have to do, but yet I have to do what's right by the patient too? I mean, I don't know. I don't know if I could ever be in your shoes, because I would just be like, you don't really want to do this study. And I'd probably turn everybody away once I found out what was happening. So I don't know. How do you like deal with that
I think for me,
in
the
an
middle
ethical
ground.
situation?
Yeah, the middle ground for me was I did try to recruit in that I would contact patients in our nephrology clinics database about the study. And if they were interested, I would still fully go over the side effects with them. I would say, you know what, this drug, like, I've seen that it helps maintain kidney function, which is very cool. It does come with lots of side effects. So let's talk about it. And if they back out because of that, then I tell the pharmaceutical company, like, hey, I am bringing patients in. They're backing out because they're concerned about side effects. And there's not really anything that they can say to that. They can't be like, well, the side effects don't matter, you know? So
Right,
I
right.
could just go back to, well, the medication has these known side effects. So patients are not willing to get on board with that. And there's not much I can do, because we can't like lie to the patients about
Of
side effects.
course.
That's
Right.
usually what got them to back off a little bit. So
Right. I mean, I guess, yeah, research nursing is so interesting to me, but I would always think of like some of my friends when they were in research nursing and just talk a little bit about it. I'd always think like, are you like the used car salesman? Like, come on, you be in this be in this trial. It's clinical trial that's gonna blah blah blah, and
yeah.
like really try to sell something. But from that ethical side, like you're talking about, it's like, oh gosh, all these side effects. There's actually, a lot of harm that could be done for them being in it. So, I mean, I can appreciate how neutral that you remain, and how positive and professional, that you remain. Because even just talking about this topic, you can tell it kind of lights a fire, but you're still taking a very like just, kind of stoic, just even keel, neutral approach. So you're probably in the absolutely right field for this. And by no means are you a used car salesman.
I am lucky to have a good boss. Like, she backs
That's
my
good.
play always. So she's awesome. So if I'm hesitant about something, she'll agree. It helps a
Oh, that's
lot.
awesome.
I thought
Yay.
So
I thought this summary was really interesting when what you just went over, because you said that the research doctor is not usually there. And so
mhm.
I also thought about like it puts you in a really bad position too, because if they have further questions and stuff and you can't get a hold of the doctor, like what do you usually do in that situation if they have more questions about the consent form?
Yeah. So that doctor is almost never available, which, like I said, if the FDA finds out, he'll get in trouble. Most research doctors are typically pretty busy, and so that's not uncommon, but his is like way out there. There's something called sub-investigators, which are they're like doctors and nurse practitioners who can kind of be backups if he's not available. So usually I'll just call them, and they've always been really great. Like, I work with 2 nurse practitioners who are always available and love to come in. They're awesome for helping out whenever I'm like, Brittany, this patient wants to know about like the therapeutic action of this drug. Can you, come talk to him? And so they're pretty supportive.
Oh, that's good. I didn't know that there was like a mid-level provider that you could go to. So that's really good to know that you have someone to go to. I can definitely see how you're kind of pulled in both directions. So like, you said the patients, you're advocating for them, but then you're also still working for the pharmaceutical company, or the company that is employed by the pharmaceutical company. Know you said that you work with children occasionally. Are there any, like, I know that that's a vulnerable population to do research on. Are there any other considerations that you kind of take into account when you're working with pediatrics?
Oh yeah. everything you do with adults, but on a much simpler level. Like you really want to make sure the child understands and that the parent's not pressuring them into it, because there are payments tied, of course, to the visits. So you want to make sure that the parent's not pushing the child into this and that the child will actually get the money. That one you can't guarantee, which is kind of hard. And then parents have their own, or guardians have their own form that they have to sign as well, saying that they were present at the discussion and they feel comfortable allowing their child to be part of the study. And then you have to make sure that the child's really up for it. Like for the polycystic kidney one, that one allows children, and you have to make sure they're going to be okay with all the blood draws. We had a patient in that study who wanted her daughter to enroll. Daughter was a teenager, but daughter was like, no, I'm not doing the blood draws. So we said, okay, if you don't want blood draws, you don't have to do the study. I mean, she's got a lot of blood draws in her future because she's got the same condition, but if she doesn't want to do them for the study, she's not going to do them. So
It's so interesting.
It is.
It's awesome.
yeah, it's to wrap it up really quick, it's not all bad. I want to say, like, I know I complain about the ethics, but sometimes you do get to provide really cool treatments for patients. So you get patients sometimes who've tried every other option and nothing has worked for them, and it's kind of a Hail Mary. And then when the drug does work for them, it's actually really, really cool. So not
Yeah,
only do they
that's
get like
awesome.
some $10,000 medication for free, they get paid $100 every visit, and they get all this extra time with doctors. So not all bad, but a lot of ethical issues to
For
sort out.
sure. Yeah.
So
And I applaud you for being that advocate for your patients. I think that that's really important for us to be doing.
For
So,
sure.
and Paul, when you're doing your informed consent, do you ask them to tell you in their own words what they've heard?
Yes.
Okay.
Yes. That
Right. And so
that is,
and this is really weird because I'm working on an advisory opinion right now for the Board of Nursing, and it's so how do I want to say, I don't want to say it broad, but it allows a lot more than what we think that they should allow for an informed consent. So I'm working on to try to narrow it down a little bit to make it to the point, putting in there about the wording and about that the patient understands. So I appreciate that. And if you put all this information in there, then I'll take it back. Again, I'm stealing from you guys, so that's why I do this.
That's awesome.
So, all right, nice job, you guys.
Awesome.
Okay, thank you.
Was it that terrible, Nina?
the first 2 minutes were rough, and then it got better.
And it always starts out rough. You're like, oh my gosh.
Yeah.
All right. Goodbye again.
Okay.
Goodbye.
All right. Okay. Since we're talking about informed consents as well, I think this is a good opportunity to proceed with mine, with my post. So give me a second. Let me share my screen because
Oh,
and
you're
I
gonna
will
be fancy.
I
I'm not
will
sharing my screen, so
I apologize. I
okay,
apologize in
fancy.
advance. I love using mind map. So wait, can I Sam, can I
No, I
get
think Sam is the owner of this, right? Or
Yeah.
do you
This
have
is
to
gonna
like
be- Yeah, hold on. This is always a problem.
way to go, Paul?
sorry.
I wasn't ready for this.
I'm like, I am so not technical, so I don't want to push any buttons. You might lose me for the evening. So
But just remember, it comes off his time.
Oh
yeah.
okay.
Oh, she started the timer already. There you go.
Now
Okay,
try.
well,
Now try, Paul.
Okay, let me try it. Alrighty. Okay. So let me share my screen real quick. Okay.
You're 12 minutes in. I'm just
Thank
kidding.
you. Okay. Is everybody able to see my screen?
Yes.
So okay. So I wanted to so my post is actually a reflection. Because when we were in class, what really struck me is the idea of informed consent and how it is it affects everybody that is you're taking care of. Like what Nina said, when you're in research, you're taking care of the patient, and at the same time you want to further learning and research and innovation. That's why you have that you have to have that sweet spot. For me, um, like I said in my reflection, I delve into kind of bit of a rabbit hole on autonomy and informed consent. So if I can zoom in,
You
I
made a
tried
full
to
mind map just for this assignment.
yes.
I am so impressed.
I was gonna say, it took me hours to do just my assigned mind map, let alone add
It-
another one.
I'm not really good at putting everything in words, but I can map out what I wanted to say.
He wants
So
brownie points.
Yes.
okay, all right. So let me go into how I went about doing my self-reflection. So the central theme of my post was again about um, thinking about autonomy. How do you say that you have independence? You are able to say that yes, I'm going to do this. Yes, I will take on this procedure. So I start by thinking about autonomy. And from the readings that I did, I went on and looked at its definition through an ethical book, which is according to Beauchamp and Childress. Autonomy is intentional. It has to be within an understanding and it has to be free of control. And then I try to relate that with how I do my care, which for the most part is basically the ANA Code of Ethics. But what really struck me was the promotion, advocacy, and protection for patient rights. Because, I mean, my patients are vulnerable. I see my patients for the most 5 minutes, and then they go under anesthesia and they are asleep the whole time they're under procedure. So they don't know what's happening. They don't know what's going on. We're supposed to be positioning them. We're supposed to be making sure that they are safe inside the operating room. And that takes a lot. And that is some of the things that you want to consider when you bring a patient in the OR. I take, for example, that one old lady that I was talking about in my post. She was 90 years old. And every time I always ask the same question: can you tell me what we're doing for you today? And it just tells you everything that they know about what's going on. Some of them will say, "Oh, I've seen so many people, I don't even know what's going on." And you then proceed to question, then why are we here? Why are you doing this? Do you understand what we're going to do for you? So in the case scenario that I posted, that lady understood everything, and she stood out because she knew what was going on to her. She knew that she was going for a hip surgery. She does not want to do it, and it's the daughter that wanted to do it, not her. And she was actually, it might sound bad to say it, but I think she was coerced to undergo that procedure. So that's where the code of ethics that I had to uphold and say, okay, you know yes, I understand that she needs hip surgery. It would better her, but at this point the patient did not want it. Bottom line is this person doesn't want to do it, and she's doing it. She's still doing it. So she's being forced to do it. So that's where I'm at. Then I proceed on issues. So that's when I thought about, okay, according to the Graves book, beneficence over autonomy. In that scenario, it was definitely it's her autonomy. She did not want to do it. She is old. She is frail. She does not want to go under surgery, but everybody else is telling her this is good for you, whereas it's not what she wanted. So I mean, at the end of the story, to make the long story short, it was she 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 was able to she was able to defer the surgery, but at the same time, everybody else was mad at me. The surgical team was not happy with me, and everybody was not happy with me. But at the same time, it's my patient, and it's the patient's choice. So that's where conflict of interest comes in with the informed consent. One thing that I would really like, and I enjoyed reading the Beauchamp and Childers ethics book, is there was a section there that says about what it is for an informed consent. What are the steps or the elements of an informed consent? And it really, and this is what I'm showing out here, is there should be voluntariness and competence, so the person understands it. Disclosures, recommendation, and understanding. That's from the person that's telling what's doing it, and then the decision. Did this person decide to go for it or not? And so, yeah, that's pretty much what my reflection was on this whole topic. In practice, I encounter it all the time, and I'm it's funny that when I was reading this in practice, if I become a nurse practitioner, um, how do I implement that informed consent? And that's the next reflection that I'll be doing. But as of right now, this is where I'm at. How do I make sure my patients benefit from the treatment that I will be giving, and how do I not, how do I uphold their rights as a patient? How do I take care of them, in an advanced practice role? And it was a really good topic, and that's pretty much it.
Yeah, reading, talking about informed consent, it just makes me kind of, just look at it a little differently and process it differently. I still work PRN bedside, but I work in OB. And so we have a lot of your baby's down, we got to go to crash section, we're heading back. And, it's just kind of like a verbal, situation. And we kind of just tell them what we're going to do in situations without kind of really giving them the whole gamut of, okay, this is what's going to happen, this is that. It and part of it is like, okay, well, we're doing this for the best outcome for mom and or baby, but I also, you sit yourself in the side of the patient. So we're going back to the OR, we're going quick, or it doesn't look like we're going to have a vaginal delivery. This is why XYZ. We need to get your baby delivered. Baby's hypoxic, whatever we're saying, and the patient's refusing. No C-section. No, no, no. They have a right to do that. Absolutely. But we know this outcome is going to either end in a crash situation or a really bad outcome. And so I find in situations like that, we're giving them all the information, but like you had just made a mention, it's like, your patient was coerced into a procedure, just kind of like, because people listen to us. And, so I do think there needs to be a little bit more, especially in my field, on the front end, as far as, there is a chance that your body, your physical self won't handle labor, or that your baby won't handle labor. In those instances, we do what we need to do to make sure that you and baby are safe, to where there could be a C-section situation. Of course, we have forms that they can sign, but back to Nina's point, it's like you just tell them the quick little points and then they just sign it. So you have something to scan into their chart. But are we really informing, our patients in situations like that? Just we're go, go, go. I know what we need. We need to get it done. Doctor's on board. Let's have it. But just kind of reflecting, just thinking, hearing what you said about your patient, and they were coerced, and you're like, do you really know what you're doing? Do we really understand what you're, getting into? I just don't see sometimes that side of surgery, because usually if we're doing surgery, it's we gotta do some
Yes.
surgery. And
Yes.
and patients, for the most part, they're like, yes, please do whatever, like save my baby, or yeah, no problem. But we have run into those times where they're just like, no, I refuse a surgery, or there's been a bad outcome, with I had a
Yes.
patient who had a C-section with her first baby, and it ended up in a fetal demise. Okay, so she doesn't want to go back to the OR. However, it was leaning that way. And, to get somebody to, sometimes I feel they're talked into situations instead of like, allowing them to make those decisions. And there is an ethics where you're like, oh, I know you need this, baby has to be delivered like 3 minutes ago, but I understand where you're coming from too. And you're just kind of standing there like, I don't know what to do. And that's when you call the doc to come in and it's out of your hands and let them
Yes.
make that decision, or, talk to the patient in that way. So yeah, it just, yeah, it's
Mhm.
interesting to see from the, other side.
Mhm. What's interesting too is for the surgical standpoint, surgeons can override patients' autonomy, especially like in emergency situations. You can definitely override it, but it's always a two physician consent. So
Yes.
it almost paints a picture of physician A talks to physician B regarding this patient, and physician A agrees with physician B saying, okay, yes, we can proceed. This is an emergency situation. We need to proceed and we need to override somebody's decision making. But yeah, I totally agree. In emergency situations, sometimes the benefits need to outweigh patient's autonomy. But for the most part, I think, everybody should understand what they're going into
No.
before they go.
Yeah, and I absolutely agree with that too. So
Okay.
I
All
really
right.
Oh, Paul, I was just gonna say, I really like how you brought up the conflicts of interest because I work in the neurological ICU. And so a lot of times these doctors, they fly in at like 4 or 5 in the morning to try to get some consent from these patients. And often like our patients are oriented to self and that's it.
Mm-hmm.
So I walk in on them trying to get consent from these patients because it's more convenient than to call the family members at that time. And of course, I've been placed in that situation where I'm like, no, like you need to call the family. And then I have, the resident, the attending, and they're all mad at me because I'm just trying to do what's best for the patient. But I just think it's interesting how often we're put in that situation.
I agree. Yes.
And neurosurgeons are the worst.
They are the worst.
They really are.
It's like an
I had one
inconvenience to get
really angry
consent.
with me because I did the same thing as I'm hearing you do, and they've decided that they didn't want anything done, and that it takes away from them getting cases, but it also takes away some of it's all a matter of who they are and how they present themselves. I don't know. It really got me upset. So
Mm-hmm. I agree. Some providers can be real caustic, especially during emergency situation, and you're trying to make sure that everything checks and everything is on the same page.
yep.
Paulo, I was going to ask, because talking about those tensions with the surgical team,
Yes. Mm-hmm.
what's your strategy to keep from being steamrollered by him? Because my thing is email. Like I can just send emails. Like I'm not at risk of being steamrolled by Big Pharma. But with the surgeon right there, like if he's upset at you for delaying the surgery, or I don't know how it works, but how do you keep them from pressuring
I
you
say,
into doing something you don't want?
okay, this might sound unprofessional, but for most OR nurses, we say no. It's not about you. It's not about your process. It's not about your surgery. It's about the patient. Or sometimes I say it's about me.
Yeah, I do too. I
Yeah,
kind of say the same thing.
yes. There are multiple times when we encounter hostilities in the OR. Most of the dialogue turns very aggressive, and especially with this scenario, the ethics committee was brought in. The person who brought in the ethics committee was not me, but my charge nurse, because I was getting cornered by the resident. Everybody was asking, well, are you sure that she's ANO times 4? Are you sure this is this? And I'm like, I asked the patient, can you tell me can you tell me who you are? Can you tell me where you are? What are we doing for you today? He answered everything properly, and she answered it coherently, and and they were steamrolling. That's why the ethics committee was brought in for this situation, and that's when I looked at those elements too. When I showed it to you earlier, these elements is because the ethics committee actually went through, and this is what they asked. It's like, were there disclosures? Did the patient understand what they were going into and all that stuff? Was there any authorization? That was the biggest thing. Is that this patient is not letting you operate on her. Yes, she is 90 years old. Yes, she has a fractured hip, but she does not want it.
Mhm.
And it just it's a when they talk to you, and then they start trying to press on their issue, their agenda. It's always, for me, I face it as it is. I tell them no. I tell them this is it's not about you. It's not even about me. They will tell you that you're being capricious, you're being too vain about your stance. I say no, this is not about me, and this is not about you. This is about the patient.
That's
I
exactly
wouldn't
right.
yeah, I wouldn't want my mother to do this, to go on, under your care when you're doing this to her. So yeah, I mean, it was a bit it's a bit of a dramatic point, but yes, um, that's where I'm from.
That's good.
Okay, all right.
And
Mhm.
while you were talking, when I was working on the informed consent earlier today, I found this article in the Journal of Hospital Ethics, and it talks about autonomy and informed consent. So I went back to find it so that I'll send it to all of you guys
Yes.
to call when we get off of here. So thanks, Paul.
Yes,
And
thank you.
you.
and you're not going to get brownie points for this, but I'm going to tell everybody in your group in 709 that you like to make maps, and that you're going to do the maps for them from now on.
Dang it, I'm not in your group.
Yep, you lose.
Okay. All right. Who wants to go next? I'm gonna stop my screen sharing.
Yeah, I can go next.
Okay, go for it, Sam.
All right. Oh, sorry.
Me to last. No, it's okay. It's
I was
fine.
like, you can go. I don't care.
No, go ahead. I'm just yeah, talking on these things makes me so nervous, but I'll wait.
I know.
I'll deal with it. Go
I
for
get
it.
nervous too. So, all right, mine is like radically different from everyone else's. I think
So's mine.
okay. I think mine was kind of like a personal reflection as like a reaction to what I saw and what I read. So I know that in class we watched the video Right or Wrong, How Technology Transforms Our Ethics. And I feel like that sparked a lot of conversation in class. I didn't really speak up in class. I just kind of like sat there and like learned more about it. And then I went and watched on my own because it like really blew my mind the way that he was talking, because like he discusses how technology can radically change our ethical and moral stance. And this is in relation to health, political, or social topics. I thought it was really interesting because he brought up this point at the end of the video, or it was at the very beginning of the video, but he brought up this point where people are afraid to speak their minds, post, or give an opinion in public setting for fear of ridicule. And I guess I've been kind of feeling this like the last couple of years, and I haven't been able to put my finger on what I'm feeling. And I guess I didn't even realize that it related to moral stances or ethical stances, but I just like, it really resonated with me. So I found myself asking, like, why do individuals feel the need to shut down the opinions of others to be like quote unquote right? So I went and did some more research on my own, and I found social moral change, which is a definition of an ethical principle that reflects how individuals' ethical and moral stance on what is right or wrong changes with technological advances, which I'm sure we have seen. And he gave many examples in the video. And what I liked about the video is that he kind of showed all different perspectives, and that really shifted my thinking. But it's basically how we perceive what is good or bad and right and wrong. And what I liked about this article was that in recent years, we've seen that technology can rapidly drive social moral change. And then we have seen that it impacts how we perceive what is true. So I really like this fact in the articles. They talked about that truth allows us to distinguish between what is right and wrong. And so the issue with this is that technology has given us the opportunity to create more information, and often it's posted online. However, the information is usually disinformation or misinformation. And I kind of like that point in the article because it obviously creates further confusion about what is true, and thus creates further confusion about what is right and wrong in society. As well as technology has made it more difficult to sort truth from falsehood, which I think we see a lot of times in the medical fields as well. So I felt like this resonated with me, and like this isn't necessarily a clinical example, but it's something that I experienced during the COVID pandemic. A lot of individuals and organizations, as we know, were posting false information online or misinformation, and it fueled a lot of debates. And I know that a lot of us probably felt this. But at that point in my nursing career, I felt like it was like the one time that I couldn't really speak up because I was afraid of being, saying, oh no, you're wrong. And I thought that was interesting because, we were the ones that were actually experiencing it firsthand with the patients. So as the video depicted, which I really liked this metaphor, that as we are like a society, we're stuck in a trench and we feel that we can't trust individuals in the trench or those in a different trench without the fear of being shot or burned or canceled. So I don't know about you guys, but I still feel like we are stuck in this trench. Mostly because I have a fear of like walking across what he would say no man's land and sharing my opinions. And then I'm hoping that as we move forward out of hopefully from the pandemic and further into the future, that we can have this social moral change where individuals become more accepting of the opinions of others and where they're not so rigid in their beliefs. I feel as like we've been already talking today, I feel like it is moving that way and everyone's more understanding. I just feel like I'm really happy that I kind of watched the video because his perspective put a name and a face to what I've been feeling with all of these ethical, moral, even political, I'm sure some of you have felt that way, standpoints. And especially in the medical field, because I feel like a lot of times, even my patients will come to me with the misinformation they read on the internet and they truly believe this is true. And they'll say, no, that's not what I read. And they'll go against like your care plan because they're like, or your, what you want to do because they're like, oh no, that's not right because that's not what I read on the internet. And so I feel like technology is always going to be something that we face and we have to get to the bottom of truth and explain to our patients in the best way that we can that no, this is like what is actually true, even though you read this misinformation on the internet. And that's kind of like was my reaction to the video. I just thought it was really interesting, all of his different perspectives, because he kind of shifted the whole paradigm in my mind of like of all the expectations and what we actually perceive to be true. So my mind's a little bit more of just a reflection on that video and kind of it led me to do more research on my own. So that's kind of my summary.
Yeah, I felt the same. Oh, so go ahead.
I was gonna say, I was just really interested in what you were saying, just about feeling like even though you're a COVID nurse, like you still can't talk about it. Like I just straight up deleted Facebook. I got so sick of it. Like I tried to be like, no, like here's what we're seeing on my COVID unit. Like doctors aren't artificially inflating COVID death counts by putting COVID down as the death of like every single death, and I ended up just straight up getting rid of social media. I got so sick of it. So I liked what you put about just feeling like, even though like you have that firsthand experience, that it's just so hard to argue with these people who are going off of misinformation or, third hand accounts.
Yeah. And I feel like at the end of the day, like this misinformation ultimately leads to like some providers not taking as good of care of patients as they can because like fear of ridicule and like obviously trying to convince them that what they're reading online is not true. Like and like as to your point, I had people asking me if I was getting paid to lie about the number of patients I was seeing. And it was wild, as we all know.
Okay. Hello? Can everybody hear me?
Yeah.
Yeah.
Okay. All right. Sorry. All right. So yeah, Sam, with regard to your post, what was really interesting about it is that I I resonated with most of what you were saying, especially during COVID when it's not just the amount of misinformation that was out there, even with the nurses that you work with and the people that you take care of. It's just it can be frustrating and it's funny because you want to give your patients the accurate education, accurate information, but the thing is sometimes it's funny because I just remember one of my friends, she works in ICU during COVID. She lives in Michigan. She was venting one day and she was talking to me and she was like, I have a patient that told me she's having COVID and she was actively like having actively decompensating, I guess. But what she said was the patient was still denying that she has COVID because the diagnosis that she had was pneumonia. And she was it was just, sometimes you really can't change people, but misinformation can impact a lot of people, and it just it's it's something that, I think every provider should, should stand their ground and, tell them what they believe is true, because, truth can be relative, but at the same time, that's why we learn, and that's why we move on, is because, we learn from our mistakes and we correct it. Yeah.
Yeah, I totally agree. I think, like you said, the main thing is, especially once, I become a nurse practitioner, is standing up and stating like my truth is what I know to be true. As far as you said, it's relative, but as far as what we've learned in school and what we know to be true thus far in our medical education, I think that was kind of the point too, that as I was reading, is like sometimes it can be hard to stand up against some people, because some people are so rigid, and sometimes they get really nasty and kind of will start trying to put you down in a way
Yes.
to make them, I don't know, seem more true, or their truth, mean more. So I think that's something that I have to also address as I become a nurse practitioner, is how to like stand up for what I believe is true in a manner that's respectful of another person's opinion, obviously.
Yes.
Yeah, and I think with that we can learn from each other because I mean, you said earlier that you think that, we're going in a different direction as far as maybe people are coming together more now and, kind of seeing other people's. I actually think the quite opposite. I think that everybody has an opinion now on everything. And you either agree to disagree, or it's like there's just no common grounds. I find if there is somebody who has, you do have somebody who's just like, no, that's not correct. I don't have that, I don't have COVID, or I don't have this. I think it's important that we're active listeners to what they are thinking and what they know and what they have researched, and hear from them so that, we can have more of a conversation, because I find I hear a lot of, no, this is what's happening. This is what's going on. This is not true. It's misinformation. It's this. And that puts up the other person's defense a lot. Like, no, that is what I believe. And so you're understanding, because we're educated and we've lived it, we've breathed it, we're in it and stuff like that. But that person might not be. And so where they're coming from and their history and their thoughts and hopefully their research. And it's like, okay, I'm understanding, you XYZ, you don't want to do this treatment. This is the treatment that is this. Well, can you explain to me, why? Where are you hearing this information? How does this affect you, or what? And then we can, I think, better educate. But I do think there has been, at least in what I see, more of a like, no, you're wrong type of stance from both sides. And I don't think anybody is coming together to understand each other's side. And I think there's so much more division. I know that when COVID happened, and we were floated, we had COVID patients down in OB, and I was taking care of, high risk COVID patients. If they didn't need to be on high flow, they were down with us until they needed, higher flow than we could administer we have an OB high risk. Then they would, we would call it upstairs because the ICU is upstairs. But they would, head upstairs. So sometimes we'd be floated, and I'd be asking a lot of questions, and I'd be like, why are they doing that to that person? Oh my God, why don't they just X, Y, and then I would be even shunned. Oh, well, you work in OB, you wouldn't know. And it's like, well, I'm asking questions because this isn't something that we would normally do. This isn't how we would treat this patient. And, I'm really trying to understand. And it was just kind of like either I was with them or I was against them. And it wasn't anything like that. It was like, I just want to understand. This isn't my wheelhouse. I don't get why that patient is being treated like that, or given that medication, or, lack thereof, or whatever. Just, oh, you're either with us or against us type of situation. I'm the one who would come up and put the warm blankets on everybody and turn down their alarms. And, that's just how they would, see me as the OB nurse coming up there. So, yeah, I don't know. I'm not sure I agree that I think everybody's starting to come together. I think that there's such a divide, and it did ring a bell. Like in class, I just sat back too. I'm like, oh gosh, this is going to strike a nerve. A lot of people, where's this conversation going to go? Because I do think it's like one way or the other. I don't feel that we're finding middle ground for a lot of that. And, it is sad. So, hopefully as we all become, nurse practitioners and there's more of an advocate, we can sit down and have conversations with somebody else's point of view rather than a this is what I know, and this is how we treat, and this is what we're going to do. If you don't want to, that's fine. You have the right and the autonomy, and you can decide. But this is what we're going to do, as opposed to like really listen to their side of it. So, that's was my take on it.
Yeah, no, I totally agree. I think I misspoke earlier and I think that the conversation between us right now is really good. But I don't think that's reflective of the rest of the world or the
Oh, you were talking about us.
us right
Oh,
now.
okay.
Yeah,
I thought
no.
you were talking about globally. I'm like, wait,
No,
what?
I think
Where do you work? I want a job.
I think we're more divided than we ever have been.
Oh, okay.
In human
Yeah.
race,
Okay.
personal. I mean, as far as I know, but I think as long as I've been alive, which isn't super long, I think it's still very divided.
Okay, I agree with you then. Sorry, I took that wrong. I thought you meant like just in general. I didn't mean, yeah, I think we're having great conversation for sure.
Yeah.
All right. That was a good conversation. That was really good. Lisa, do you want to go
Which-
next?
I have to. I have no choice.
Well, I could always put 2 cents in there for you and then, just say, oh, this is what Lisa said. Because
Okay.
she's just an
Oh.
OB nurse. So,
Okay, there you go.
Oh gosh.
I'm sorry, but I hate when people do that piece. You're just,
Mhm.
you're
Yeah.
just a new grad. You're just an OB
Oh,
nurse.
yes.
You're just the ER nurse. You're just the ICU nurse. You're just a med surg nurse. You know what? We all have our strengths.
Yes.
And I can tell you, because I have to go to OB to see some of my patients. And I have one of the OB docs and I have come to agreement. Sorry about my French, but this is how she and I talk. We would say, I said, I don't do this shit. And she goes, well, I don't do the shit you do either. So we'll be really good.
Is it
taking care of
Dr.
people."
Moon? Dr. Moon?
Uh-huh.
Yeah, I love
Well,
her.
I know.
That
I
sounds
know
just
you
like her.
knew, but-
I work at Shea, so
Yeah, I know you do.
yeah. So
But
it's like
it's,
that sounds like
it's
Dr.
just
Moon, but she
because-
does know a lot. Don't let her fool you. She's amazing.
Oh, I know she does. That's why I
Yeah.
love her.
Yeah.
But
she's-
it's really real. I mean, that's not my forte. I can't take care of oncology patients.
Mhm.
I don't, I have the caring piece, but that's not what I do. And if each and every one of us said, I'm going to be an OB nurse, I'm not going to do anything else, who's going to be able to take care of the surgical patient, or who's going to do this and that? So, you have more knowledge to take care of an OB. And I'm sorry, but I would not want to be you at times, because when things
I
go
don't wanna be me
wrong,
at times.
they go so wrong. And it's nobody's ever told you when you were pregnant that those things are going to happen.
Yep.
And if they told you, there would be less and less people that are pregnant.
Correct.
So Paul, you can't get pregnant now. I told you all the bad things that
Don't do
happen.
it. You were thinking about it, don't do it.
But anyway, sorry, Lisa,
Okay.
you go.
It's okay. It actually, it's quite interesting how today has flowed, because I do think Nina's started it and then Paul's capitalized on it and then Sam went, and mine is kind of right there with Sam. Mine is more from a reflection, more of a feeling, and it kind of brought up some personal, some life personal situations with me, but also just what I see, in practice. So I was really kind of intrigued by our conversation when we were watching, I think the same video, but just talking about, just treating everybody. We were having a conversation in class, treating everybody the same. And then we got, conversations related to like the transgender community, and also the, the African-American community, and the nurses were talking about, there was one student in class who, Caucasian blonde, who's like, oh yeah, and I've never been asked that. And then the other African-American nurse were like, we get asked that all the time. And, it just kind of made me think like, yeah, wow, this really is, something that's from an ethical standpoint, because my whole situation was, I was talking about the code of ethics, the provision 1 that states the nurse, practice with compassion, respect, inherent dignity, worth, and unique attributes of every person, which of course that is what we have to do. And I think as nurses, we just see it that way, but we need to, react and spawn and care for and treat. But unfortunately, I don't see it in my own practice sometimes with other nurses as it relates to like the African American community. I think we have so much right now invested in teaching people about the transgender community, and we're told how to treat them, how to act. We're told to make sure that we use their pronouns, talk to them about what we want. And again, working in OB, I have had a transgender patient now. And so I think it's one of those where it's like, okay, we have to say this, don't say that. We have to really make sure that we're, not offending and not, bringing our personal bias into it and taking care of the human. And there's so much education behind that, which it's great. That's wonderful. I think that we need that. And with the evolution of time and patience and humans and people, I think we're always evolving, and we need that. But unfortunately, I don't see that happening with the African American community, that there is not a lot of like training or understanding. It's like, why can't we treat them with the dignity, to the respect, the level of the level of care that you would treat a transgender person, or that you would treat your same race or a Caucasian person. The health disparities in the African American community are higher. They have higher rates of all diseases, and genetics can play some of a role, but I think that plays into, oh, well, it's just genetics. And, oh, yep, you have heart disease. It's just your genetics. Where it's like, no, I found an article where it was really talking about the respect of the providers towards like a patient, especially from an African American descent, is crucial to patient connection, is crucial to patient informed consent, autonomy, patient following through with your plan of care. From a personal standpoint, why this resonated with me is because I've seen both sides of it just in practice, how an African American patient will come in. And I've worked in psych, and I've worked, OB, I've done NICU, I've done, everything in OB, and also in psych. And the African American patients are just not treated the same. They're not. And from a personal standpoint, my ex-husband is African American, and I have 4 children who are mixed. And it's the same type of the questions that we get when I've gone. I'm very close with his family, so when I go, I'm the only one medical. So if I go, ask them questions about, well, what did the doctor say? Or I go to an appointment with them, it's almost like they're talked down to. It's almost like, you don't know, you don't have resources to even tell you this. And it's the way you eat. It's the way you live. It's because you haven't had this. It's because of all this. And it's almost like this huge stereotype that gets put on them. And it, I just like, I get so fired up about it, because I just think there's so much out there right now, which I am okay with it. And I think it's wonderful about all this transgender movement, and do this and be kind and treat them this way and do all that. But yet somebody who was born an African American, who had no choice, is treated horrible for the person that they are. And I think from a medical standpoint, we have to do so much better. Because again, I've seen it on both sides, just in practice, and how other nurses will say something like, they'll come through OB triage, and it'll be like, oh, they'll see her name, and it's an African American name. And before you even go in there, there's already a stigma just from the name. And it's like, why? And though I'm really quiet when it comes to like in class. I don't like to pipe up, because like you said, a lot of us just keep our, we don't want to, say a lot of stuff and offend people. But in those situations, those are when I will speak up for sure and advocate. And I was like, you know nothing about her. Go see what she wants. She might be, the CEO of our hospital. Who knows? Like, I mean, how can you just like see somebody's name and already have a preconceived, oh, she probably doesn't have prenatal care. Well, really? Seriously, right now, where a transgender person will come, and it's like, okay, they want to be they don't want the gender of their baby. The baby's going to be, named Taylor. They're going to let and it's like, okay, all right, okay. And it's just like all this, you know, this is how we're going to, you know, make it happen. But it doesn't happen like that with the African American community. And it's so sad. They're, you know, they're talked down to, they really are. And just seeing it from a family member perspective, that's like they're not given a lot of education because it's almost like there's this stigma that they're not going to understand anyways. You know, well, it's the lifestyle you live, it's a type of food that you eat, you know, it's everything's fried, isn't it? Like, what? Rather than having a conversation and connecting with the heart space from that human, from that person. And it really upsets me. And I think, you know, just from a personal standpoint with my family, you know, and then my children having to deal with and go through stuff like that. But just obviously, and also seeing it in practice. So seeing, you know, both sides of it. And I do have to say, because I work at 2 different hospitals, and I've already told you one that I work at, but another one I work at is more of, you know, one is a very more affluent type of clientele, and one is more, you know, like access, no prenatal care and stuff like that. And there's a huge difference between the nurses too. There's a little bit more compassion with the nurses who deal with the patients, maybe with no prenatal care a little bit more, or, you know, access, lack of knowledge, education, understanding, as opposed to the nurses who, you know, usually take care of the more educated, affluent, you know, Caucasian, white, you know, counterparts. So it is also very interesting how your environment plays a huge role in, you know, people's, you know, stigma and biases. So that's what I wrote about. It was more of a reflection and kind of like a feeling.
Nice. Thank you so much, Lisa. So jumping on what you were saying and kind of piggybacking on what you're saying, when you say, I keep on thinking about bias when you were talking about the African American population and everything, and makes me think about the population that we, you know, even people in surgery, because people in surgery don't necessarily see that perspective from the outside. You see, if you work nights um in surgery, and it's a level 1 trauma center, you encounter people from all walks of life. They can be white, they can be black, they can be transgender, they can be homeless. They are in there because they need attention, and they need attention now. And yeah, one thing that you want to actually look into is you have to check yourself first and see, okay, what are my preconceived notions? Okay, this patient came in, he got run over by a car. This person is black. He is, you know, he may or may not be homeless or whatnot, but you can actually, and I agree, you can actually see how the medics bring the patient in and say, this is a 57-year-old male, you know, African American, blah blah blah, hit by a car at 50 miles an hour or something. But the point is, you can actually hear the tone on how different it sounds when it's white versus somebody that's, you know, not white, or somebody that's a minority. I had patients that are transgender, that request that they be called them during surgery, and it's hard. You know?
It's so hard.
So the nurses are, we will, what surgery are we doing for them? It's a weird, it's not, I don't want to say weird in a bad way, but it's definitely a different approach and a different kind of respect that you want to uphold for your patients.
Oh,
And
for sure.
I think it's a very I think with our modern times, I think it's very important for us to start considering those things and being more conscientious about respect and how we take care of patients.
For sure. That's what I was saying. It's like more, you know, cultural competency, but more, you know, there's so much cultural competency relating around transgender right now. It's like, well, why? Great, perfect, keep it. Don't let that go. But also bring up, you know, cultural competency. And you're right. It's like sometimes they'll bring a patient in from the field, you know, AMBO, and it'll be like, you know, we have a, you know, G3P1 21, blah, 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 blah. That's it. then we have a patient who's a G4P3 black. Mom's like, well, why didn't you say the other one was white? Like, what is this? Why does this have to do with anything? I don't understand. Why does that have to, why is that? I mean, it is important and it should be said, but it's not with certain, and it is with this one. It's just like, okay, and I'm still going to treat them the same, or at least we should. And unfortunately, we're not. As a collective whole, I think all of us here would do that, but I think as a collective whole, from what I see, it's not, unfortunately. So
I was going to say, adding on to that, it's crazy how much we don't even question. Before I deleted all my social media, there was an Instagram I followed that was a dermatology account. And I don't know if you guys have seen it, but it would show conditions in white skin, like this rash, like hand, foot, mouth disease or whatever. And then they would show how it looked in brown skin, and it would be totally different. And they would have example after example of these different rashes and skin conditions and how they present differently in darker skin. And I was like, oh my gosh, so like if you are Black or if you have a Black child, how do you know which dermatologist you can take them to and get like an accurate diagnosis if all of the dermatology textbooks are based off of how rashes present in lighter skin? Like, I'd never thought about that. I just assumed that dermatologists knew how to look at everybody.
yeah.
So looking at that account, I was like, it looks different. And how do you know that your dermatologist is actually going to accurately diagnose whatever rash that you have? So
Yep.
I was just thinking about that.
Yep. No, it's true. Actually, it's funny you bring up dermatologists, because my youngest, she had like some type of like cyst thing, you know, on her back. And the dermatologist actually said, well, I think it's, I don't even remember. I wrote it down I don't remember what kind of cyst. I think it's that, but it looks a little different in this dark skin. I'm like, okay, great. So what is it? What do I need to do? What, you know, it's just kind of like, you should, I don't know. It was just, it struck a chord. I'm just like, okay. And then it made my daughter question, Mom, my dark skin, like, is it something that, you know, and it made her question that. And then we have these open conversations about it. But so you bring up that dermatologist, that was actually just a recent incident, probably in the last 6 months, you know, that we had, but it's the same, you know, with hair. Oh, I don't know. I don't deal with black hair. It's hair. Wash it, dry it, comb it, like cut it. Like, I don't know. What do you mean you don't deal with that? It's just, it's a different world for sure.
As someone with curly hair, I would say that the hair is different, but hairstylists should know how to do it. Like, what do you mean you only know how to treat straight hair? Like, curly hair is not that much harder. Like, learn how to moisturize hair. Come on.
So you do feel my pain then sometimes. You're right. It is different, but everybody should be.
I have one person I go to who's trusted with my hair alone, and I don't even have like texture hair, so I don't.
Yeah.
It's hard.
It's interesting you bring this up today, because I actually had a case of this in clinicals today. So there's a like little girl, she was Hispanic, and obviously her and her mom were only Spanish speaking. And I see this a lot with like the primarily Spanish speaking individuals. A lot of times, like, you know, we'll use the interpreter like we should and everything, but you can see how much the ball is dropped with using the interpreter services on like past providers, because some of it, like, it was like the simplest thing. It was like treating constipation, and it should have been something that was addressed, and then, you know, she got better, and they just managed it correctly. But you could tell it had been mismanaged so much that she got to the point where it was, you know, getting pretty severe. And like reading the notes, you could just see that the ball was dropped so much, because I think it's almost like there was an inconvenience of using an interpreter, and there's like a lag time, and they're in such like a rush that they're like, I just have to get this over with, like this visit over with. And even the patient's family said like they didn't understand the last visit, even though they used the interpreter and the instructions weren't clear. And so it just kind of builds upon like what you're saying, even though it's not a different language, it's like, these are things that we have to be cognizant of, even when we are treating patients of different either races, cultures, or ethnicities.
Yep, for sure. Well, that's my time. I did it. I made it.
Nice.
So, can I tell you that this is going to be the conversation on the 20th about ethical competency? So if you guys don't chime in during that period of time, we're gonna I'm gonna call on you, each one
Well,
of you.
Sam and I are already self-proclaimed quiet ones in the class. We will probably
That's
not
why you're
call
getting
in.
called on. The two of you are going to get called on. So
Great.
but yeah, this was a great conversation, because I don't know about you, but being in a smaller group allows you to say what you want to say that you didn't want to say in class. And you feel comfortable with the people that you're with, so that you can really you know that they're not going to judge you. And, you know, that's why we tried to do this piece. And then the other piece is I hate discussion boards. So that's the other reason why we're doing this piece. So again, Paul, it's all about me. It's not about you. But I'm hoping that this was a nice way for you to do a discussion board as opposed to sitting and writing something. And really, I think this gives you some idea of other people. And again, especially with the ethical competency piece, how should we treat other people? You know, I mean, I was always brought up, you treat others like you want to be treated, and you treat your family. And that's what I go with. And, you know, I'm sorry, but I take care of probably, you know, the population that nobody wants to take care of. And, you know, I tell them straight out, I don't care that you use. I mean, that's your life, that's your decision. I just want to make sure that you are safe when you're here and we're taking care of you. And I don't want you hitting other people. You don't hurt the nurses. You could yell at me and you could cuss at me, but you don't do that to the nurses. And, you know, those are my things that I put with them. But yeah, I see it all the time. Because I have to tell you, I hate to say this, in the 40 years I've been a nurse, this is probably, I've worked at a county hospital my whole life. And so this is really hard for me sometimes even to go to Thompson Peak where they're more affluent and they are, I don't even want to say, they're very needy.
Yeah.
And I would rather work at the county hospital because they appreciate what you do for them.
Right.
So.
Yeah, it's definitely all about respect. And that article that I found and was reading, it was pretty cool. Just talking about, you know, just respecting whoever's in front of you as a practitioner, as a nurse, whoever, just that respect. And it's going to make that, you know, that connection. And, you know, people will, I believe your mind and body are best friends. And when one's not right, the other one's not right. And if you can get that connection and you can make somebody feel heard, they're going to heal better physically. And I just think we're missing the boat a lot with, you know, these things. So. Yep.
All right, guys, I'm going to stop the recording.
Okay.